Hello everyone, my name is Jacques Shimimana. I am a registered physiotherapy specialist in Neuro Rehabilitation, and today we're going to do a course we named Introduction to Neuro Rehabilitation. So we have three training objectives. The first is to describe the different mechanisms of neurological dysfunction. Like, how does it happen when there's a neurological dysfunction? And the second objective is to be able to understand and discuss the concept of neuroplasticity. This concept of neuroplasticity, it lies within the neural recovery, because as you can see, the first objective, there has been a neurological dysfunction. And then after that, there's a neurological recovery, which happens including neuroplasticity, and then we'll be discussing as we go on. The last objective is to demonstrate the knowledge and understanding of approaches used to neurological rehabilitation. Neurological rehabilitation, in case one has had an injury or any disease, there's a recovery. Sometimes the recovery is just functional based, or maybe there's a treatment, which we are calling here neurological rehabilitations, which is used. And then there's several ways, and then we'll be discussing them as we go on. So without further ado, the mechanism of neurological dysfunction or neuropathology. There's a variety of how it can happen. The first is, let's say, there has been a malformation. A malformation is, it can either happen before birth, during, or even after. That one we call an acquired. So one of the malformations is what we call Chiari malformation. This one is where the part of the cerebellum, think the cerebellum is the lower part of the brain, it extends below the foramen magnum and into the spinal canal. It actually herniates. If it herniates, it blocks the foramen magnum, and through that magnum, it's where the cerebrospinal fluid flows. It can lead to hydrocephalus, which we are going to talk about. So the second is now hydrocephalus, like I just mentioned. By the term, hydro means water, and cephalus is the brain. So it is a fluid on the brain. This is an excessive buildup of cerebrospinal fluid caused by impaired circulation of the CSF. CSF is a short form of cerebrospinal fluid. These two malformations, they are linked, but they can occur separately. One can have a Chiari malformation, which would lead to hydrocephalus. Or one can just have hydrocephalus, where there's a blockage into the ventricular system, which leads to the buildup of the fluid. There's another possible malformation that can happen. We call it spinal bifida. So by the term spina, we understand the spine. Bifida, it means two, it bifurcates. It means the spine opens. This is the failure of the vertebral canal to close during embryological development. Babies are born with this, and it has to be managed surgically right after birth, but it leaves some of the neurological pathology which need to be rehabilitated in the long term, and we'll be discussing them. So, apart from that, a pathology can occur in terms of malformation. It can also be as a result of an infectious disease. Infectious disease, they can either be bacterial or viral. In this case, we just give an example of a bacterial infection, which is very common, meningitis. Meningitis, by the term, there's meninges. The meninges, they are the layers which covers the brain and the spinal cord. We have three layers: the dura mater, the pia mater, and the arachnoid. Those meninges can be inflamed. That's why meningitis by the term. It means meninges, itis means inflammation. They can be inflamed as a result of a bacterial or a virus, and they lead to pathological conditions which affect the nervous system. There's another possible way, which we call an autoimmune disease. By the term autoimmune, it means one's immunity system, it auto-attack, it self-destruct itself, whereby white blood cells detect themselves as harmful to the body, and they start breaking down the myelin sheath, which is a covering layer of the nerve. And when the myelin sheath is broken down, we have a slowness of nerve impulse. So one of the examples is a common disease we call GBS, or Guillain-Barré syndrome. It is an autoimmune disease. We can also have degenerative disease, such as Parkinson's disease. By the term degenerative, it means the brain cells, they degenerate as a result of aging. So this Parkinson's disease, it is a disease which mainly affects older adults, and it is as a result of lack of production of a hormone which we call dopamine. That dopamine hormone is essential for the production of smooth, coordinated movement. So therefore, one with the Parkinson's disease, they will present with slowness of movement and jerky movement and increased muscle tone. And those impairments I just mentioned, they will need rehabilitation. But you can also have just a neoplastic disease, such as tumors. Tumors, they can either invade or they can compress the tissues. And they can arise anywhere in the brain or in the spinal cord. And depending on the area where the tumors are located, it will tell us what are the functions which is going to be lost or just impaired. And lastly, a trauma. One can suffer a trauma. They can fall from a height. They can be struck by a car in a road traffic accident, and they suffer a TBI. By the TBI, we mean traumatic brain injury. This is an acquired brain injury as a result of trauma. And this can also lead to a variety of neuropathology which requires rehabilitation. So I think we just spoke broadly about possible neuromechanism that can lead to pathology. Then we would wonder, how does it occur for the brain to recover? We will first have to describe or to define what do we mean by recovery. By recovery here is the reacquisition of movement skills lost through injury. In either complete recovery, the performance of the reacquired skills is identical in every way to the pre-injury performance. This is not very realistic. Sometimes we do not achieve complete recovery. But in case it has happened, it's only to be called complete when the reacquired skills are measurable or compared equally to the pre-injury performance. But we can also have a compensation. Compensation here is defined as a behavioral substitution, that is, alternative behavioral strategies are adopted to complete a task. For example, one has had an injury, an irreversible injury, and the brain will just reorganize itself to do a task using some other pathways which can be reprogrammed, remapped for it to do. In that sense, it is more of a compensation, and it's also categorized under recovery. So when we talk about neuro recovery, we have to understand what type of recovery do we mean. Is it a complete recovery? Is it a compensation? Or is it more of the things we're about to discuss? So it can be categorized into two main types. The first one is what we call spontaneous recovery. By the term spontaneous, is a recovery which just occurs right after an injury or an insult. This one, the body does it itself. But we can also have functional induced recovery. By the term functional induced, it means it is the function we do, the rehabilitation we give to the patients that will induce the recovery. So functional induced recovery here is the neural reorganization that occurs as a result of increased use of the involved body segment in behavioral relevant tasks. And this is where more of the therapists, either physiotherapists, occupational therapists, prosthetics and orthotics, many people involved in rehabilitation, this is where their role really plays on the functional induced rehab or recovery. So we mentioned spontaneous recovery. We would wonder, how does it occur? This spontaneous recovery is influenced by the return of function of an undamaged part of the brain with just the resolution of temporary blocking factors. I will use an example of a stroke or CVA, cerebrovascular accident. Let's imagine someone has suffered a stroke. A stroke can be either caused by a blockage of the artery, the blood vessel, by a clot, a thrombus, or even a fat. Or it can also be hemorrhagic, where there's a burst of a blood vessel. In that case, that area which has been damaged, there's some other areas around which we call the penumbra, which are not actually damaged but are going to lose their function as a result of either shock, there hasn't been enough blood flow and oxygen going to the brain, or maybe there's edema, swelling which extend even to that area, or there's a decreased blood flow or a decreased glucose utilization. These factors, they will cause a loss of function in undamaged area. Then we would expect that as time goes by, which is around 3 to 4 weeks, there will be a resolution of this function just spontaneously as these factors will be resolving. So this process of spontaneous recovery, it is termed as diaschisis, and it takes a short time, which we say 3 to 4 weeks. And then remember, we said we have two subtypes. We have a functional induced recovery. Now this one, it is the ability of the nervous system to modify itself in response to change in activity and environment. The brain has got this ability, but it has to be induced through function. And that's the role of the therapist, of the people who does rehabilitation, specifically neurological rehab. But it is very important to remember that brain is organized with parallel and distributed circuits that provide multiple inputs to many areas and overlapping functions. For example, there will be different and underutilized area of the brain, which we call cortico-supplemental area or association areas. And these areas, they can take over functions of the damaged tissue, and this process we call it vicariance. For example here, someone has had a stroke. Let me keep using that example to make sense. They have lost some function, but with the rehabilitation, you see them recovering function. Sometimes it's not just because that damaged area has recovered. It can be just this vicariance, because there are some underutilized areas which are being unmasked, which are being reactivated through function, and then you can see them recovering. And that one we call it vicariance. We have what we call substitution. In this substitution is where a whole different area of the brain is also capable of becoming reprogrammed. For example, there's an area of the brain which, let's say, was supposed to control the hand. And that area is reprogrammed to control the foot completely. It is a remapping. If this thing happens, we call it substitution. And I have got an example here which I think is very practical in life. For example, you might have noticed an increased sensitivity of the hand as a sensory information system for the person who becomes blind. Someone was fully sighted and then they suddenly become blind, and then they have to relearn how to use their hand as a sensory information system, how to touch something and to tell what is it, how to read the braille using their hand. So that hand is being reprogrammed to work as what an eye would do. So in that sense, we are talking about substitution. But again, this substitution also is a functional induced recovery. I mean, it needs to be trained over and over for it to occur. Still, we're talking about the mechanism of neural recovery. We have three main mechanisms of how these things can occur. First thing, we have what we call axonal degeneration, or a process we call Wallerian degeneration, because the person who coined the term was a doctor called Valerian. So this process, it mainly occurs in the peripheral nervous system. In the peripheral nervous system, it is higher than in the central nervous system. And the way it occurs, it actually occurs as a result of an injury. For example, one has had a cut on the arm, specifically on the arm. I mean the lateral side of the arm. If they had a cut here, this is a pathway for the radial nerve. So they're likely to have a wrist drop. If they have had a wrist drop because the radial nerve is cut, that insult is occurring depending on the degree of the injury. It can be a partial tear, it can be a full tear with just a compression. And like I just said, there are three things. In terms of a compression, we mean neuropraxia. It's just a compression. Axonotemesis is where the axon of the nerve is compressed. Now, in case of a neurotemesis, both the axon and the cell body, they get compressed and they can be separated. And that last one, neurotemesis, is the most severe. But in the neurotemesis and the axonotemesis, both this process occurs. And the way it occurs, it causes the distal part to disintegrate. And then the proximal part will extend itself to grow a new nerve. That's axonal degeneration and even regeneration. It occurs both in the central nervous system and the peripheral nervous system. But as the note says here, the extent and the speed of it to occur is higher in the peripheral nervous system than in the central nervous system. And there's another one we call neuroplasticity, and this neuroplasticity was even in the objective of the training. The neuroplasticity is the ability of the brain to alter its shape and its function as a result of training. So, the capability of the cerebral cortex to alter its function organization as a result of experience. This is what we call neuroplasticity. So we have examples of how it is. For example, a brain activity associated with a given function can be transferred to a different location. I have mentioned this, where I was giving an example of one becoming blind and the hand becomes more hypersensitive. That's one of how the neuroplasticity occurs. Or maybe synapses, and by the term synapse, I believe the audience would know what a synapse is, but I can also go back and explain a little bit what a synapse is. A synapse, it's a junction of two neurons where they meet. So by a synapse here, they can either be strengthened or weakened over time. For a synapse to be strengthened, we call it long-term potentiation. Here, it increases the strength of the synapse after high-frequency stimulation. I'll give you an example. If you practice an activity several times, for example, let's imagine one playing piano. The first time you're trying to play piano, you don't master it. But the more you keep training, you are reinforcing a certain pathway. And the more you train that, there will be a strengthening of a pathway that we call long-term potentiation. But on the other hand, there can also be the weakening of the synapse, which we call long-term depreciation or depression. In this case, is when you're practicing a skill and you're making errors, you keep correcting. So those errors, you will keep avoiding them. You will avoid the errors, therefore you are depressing that pathway to the point that it will even become unused and just stay there. So long-term depression here, it means important in learning and habituation. Selective weakening of specific synapses to allow for synaptic strengthening. But we can also have what we call unmasking of latent synapses. By synapse weakening, those synapses which has been weakened or depressed, they will become latent. They will just be there as a sleeping, not used. And they will be unmasked in case of an injury, where you need extra pathways to use. Here, unmasking, it means unused neurons becomes active. And they become active as a result of function. And the function has to be repetitive, task-specific. So, cortical remapping, I talked about it, how the brain, we know there's something we call the homunculus, how the body structures are represented on the motor cortex and the sensory cortex. And for example, we know the hand has got a very big area which controls the hand, the face, and the lips. You can tell because they are very sensitive. So this area, they can be remapped depending on the needed function. They can either be enhanced, they become bigger than normal. They can either be smaller, depending on what is needed. So I gave examples of how greater representation within the sensory cortex can occur for braille readers, people who read using their hand. It means their hand representation on the brain is not of the same size compared to someone who doesn't need to do that. Or maybe learning an instrument. You know, an instrument can be playing a skill. I think I've got a picture here which will tell us something. So we will see here someone is learning to play piano, is practicing the skill several times, and this learning would lead to an enhancement of the hand. You can see how the hand have a very wide space on the motor cortex, even the sensory cortex, as a result of practice. And these things, we call them neuroplasticity. Now, it has principles, just 10 principles. These principles, they are very important when you are to use them in rehabilitating people. So, here they are. The first one we call that age. Age matters. By this we mean the younger the person, the more the neuroplasticity is very active. But here, it does not mean that older people cannot have neuroplasticity. They do, but at a slower pace compared to the younger ones. We have another one we call transference. Transference here, it means when you are using these principles to train people, the skills, they need to be transferable. You need to be practicing skills which are specific and relevant to them, that can be easily transferred into their normal life. Interference here, we mean when you train them, depending on the level at which they are at, sometimes you want to avoid interference, to avoid confusion with when they are learning a skill or relearning a skill. And then we have some other principles which I believe they are very, very important, and even patients need to be told. This one we call use it or lose it. By the term, if one has had an injury or any pathology which make them need to do a neurological rehab, they need to use that affected area. Use it very much, or if they don't, they will lose it. I did mention about long-term potentiation, where we call synapse strengthening or synapse depression. So when you use it, you improve it. That is even another one I just mentioned here. Use it and improve it. These two, they complete each other. And of course, repetition matters. Repetition means you cannot learn a skill overnight. You need to practice, practice, and practice. You need to practice several times. I'll give an example. There are animal research which has been done. They were done on the squirrel and the monkeys. They were trying to see how they retrieve a pellet using their paws. They have quantified that they did around 300 to 400 repetitions for them to be able to retrieve a pellet. And those repetitions were even checked using the functional MRI, where you would see an enhanced representation of their paw or a hand on their motor cortex. And what this tells us is that the more you practice a skill, the more you will learn it, and repetition is the key for that. So repetition goes together with intensity and time. Time is very important. The earlier, the better. If one has had a neurological injury, there's a time window. For example, where the neuroplasticity is very active and you need to take advantage of that time where you can learn and relearn. So time matters. Salience, it means how specific the training is. I think I went through all of them and I kept highlighting what it means. So from here, we have discussed, we know several ways of how the neurological pathology can occur. We know how it recovers. Then we need to know what are the strategies to improve the motor functions. So strategies here, in other words, what are the approaches do we use to treat or to rehabilitate people with the neurological injuries? As the title says, Introduction to Neuro Rehabilitation. So, for you to be able to understand that, you need to know that developing a strategy to improve motor function requires a thorough understanding of the neural processes involved in producing movement and learning, and the pathologies that may affect the central nervous system. And that's what we just did at the beginning. And there have been different intervention strategies that have been developed by physical therapists or medical doctors to address disorders of motor functions. And an optimal plan of care must address individual needs of the patient, maintain a focus on minimizing or eliminating functional limitations and physical disabilities, and enhance overall quality of life. So whatever intervention you choose to go for, it must be addressing these things. It must be aimed to minimize, if possible, or even eliminate functional limitations, even enhance a quality of life. If it does not do any of this, it's not the right one to use. So we have frameworks for interventions. There are different neurorehabilitation approaches and therapeutic techniques that has evolved for patients with disorders of motor functions. The first one we call functional or task-oriented training. This approach, by the term, it's functional. The central idea to the approach is that specific task training with extensive practice. By here, extensive practice, it means that repetition I mentioned is essential to acquiring skills and enhancing recovery. Tasks important for daily interventions or daily activities, such as grasping and release, standing and walking, they are emphasized. So when you are using this model, you need to use tasks which are important. For example, if one has difficulties walking, they need to be practicing walking several times. And it involves segments targeted for training. Here, the level of difficulty is varied. At first, it can be guided. You can even be doing the movement passively. You do it for the patient, but with the aim to minimize the help and reach a point where you will be just coaching them what to do. Nakavuga kano kose tukazareba niba tukagakutamo. So, while initial movement can be assisted or guided, active movement are the overall goal. The therapist serves as a coach, providing appropriate feedback and encouraging the patient. So, as you can understand here, the overall goal is for them to be able to do active movement. But depending on the level at which, let's say it's very acute, you might guide the movement. You might even assist it. But whereby you start reducing the hands-on treatment and you become as a coach where you tell them what to do, you guide them how to do, and you give them feedback and encouragement. So task-oriented effectively counteract the mobility and the development of indirect impairments such as muscle weakness and loss of flexibility. It also prevents learned non-use of the involved segment while stimulating the central nervous system. So here, there's what we call learned non-use. So there's a possibility of the brain to learn not to use an area because let's say someone has had a hemiplegia. One side is paralyzed. So they start learning how to use the opposite side while avoiding this. So the brain will learn that it does not need to use this side. It would even suppress it. It would forget. It might even delete this side on the motor cortex, on the map. Therefore, that's something we should avoid. And this approach, it can have a very good impact because it emphasizes the use of that involved side, and it has to do it very repetitively in a very functional, relevant task. So that's why we say that it prevents learned non-use. This approach, it promotes function-induced recovery, you might tell from what we've been discussing. Therefore, it focuses on early training as soon as possible after the brain damage to utilize specific windows of opportunity and avoid learned non-use. but it does not qualify for every type of patient. That's why we need to consider the individual's past history, health status, age, and experience in designing appropriate, interesting, and stimulating activities. You have to involve the patient in goal setting and decision making, thereby enhancing motivation and promoting active commitment to recovery. The structure practice, it utilizes task-related training activities. You select tasks which are important for independent function, include tasks that are important to the patient. Here, you have to identify what are the abilities or the strength of the patient, the level of recovery, even the ability to learn, and therefore you choose tasks that have potential for patient success. If a patient is in a very acute stage, they may not qualify for this task-oriented because it's very active, it does active movement, or maybe if they have had, let's say, a traumatic brain injury which impact on their ability to problem solve, where they don't understand the instructions you give them, they will not qualify for this. But worry not, we have plenty of the approaches which might fit. So we target active movement involving the affected extremities. We can either constrain or limit compensatory strategies. You utilize repetition and extensive, or what we call massed practice. We include both supervised and unsupervised practice using an activity log. An activity log is when someone is doing something, you need to be recording somewhere to tell that, okay, they were supposed to do, let's say, sit to stand 12 repetitions 3 times. They have to tick, they have to write that they did it, for you to check. You can assist the patient to successfully carry out the initial movement as needed. So we provide augmented verbal feedback and verbal reward for small improvement in task performance. And that's why we say here therapist works as a coach, because you tell them, okay, well done, keep it up, stuff like that. So we promote practice of variable behaviors to facilitate adaptation of skills. We provide modeling of task performance as needed. By modeling, I mean, if you want them to stand, you might show them, sit on a chair, show them where to hold and how to stand. They follow you. We do structure context specific practice. We promote initial practice in a supportive environment free of distractions. Because if someone is learning a new skill or is relearning, we need to minimize distractions around so that they can learn. We need to make the task simple at first, or we can break it down for them to learn. And then we will keep varying how difficult it is as we go on. So progress to variable practice in a real-world environment. For example, if you're practicing walking in a clinical setting, in a gym inside, you should aim to reach to a point where you go outside, you practice walking, because this patient won't be walking in the clinic, they will be walking in the real world. So we focus the role as a training coach while minimizing hands-on therapy. And you have to continue to monitor recovery closely and document progress using a valid and reliable functional outcome measure. This one, to keep track of the improvement, you need to use an outcome measure. There's a plethora of outcome measures, and we need to know which are reliable and valid. And we need to know which of those are easily applied. Be cautious about timetables and predictions, as recovery may take longer than expected. So I think this slide, I already talked about it, that not everyone is qualified for that. So it depends on the degree of recovery, the severity of the motor deficit, for you to know whether the patient will go for the task-oriented training. If not, These are examples of patient who does not recover, who does not qualify for that. I already mentioned them. That's why we have another approach. We call them, this is a big title, which under it we can find sub-approaches. Neurodevelopmental training. These ones, they include developmental activities training, motor training, movement pattern training, and neuromuscular education or re-education. Neuromuscular sensory stimulation techniques and therapeutic exercise are used to alter sensory motor impairments and promote functional movements. The affected body segments are targeted for training, while compensatory movement by intact segments are not allowed. A hands-on approach is used to stimulate, guide, or assist movement for correct performance. Here you can see the difference between the first approach we talked about. The first approach is not more of a hands-on approach. It's more of a therapist acting as a coach, telling them what to do. Here it's more of a hands-on. They do everything. The therapist does the movement. He guides the movement. He's taken as the expert of the movement. These approach, they are not also appropriate for every patient. For example, highly performing patient would not benefit from a more hands-on training. Patient who demonstrates sufficient recovery and consistent voluntary movement would not benefit from neuromuscular stimulation and an intensive hands-on approach. Rather, these patients are candidates for an active, task-oriented training, which we just talked about earlier. So, in the list of these approaches, we have three most popular and traditional approaches. The first one, we call it NDT. In short, we call it neurodevelopmental training. NDT, and we have PNF, it's another one, proprioceptive neuromuscular facilitation. And lastly, we have neuromuscular or sensory stimulation techniques. So we'll be discussing each of them separately, but shortly. Let's start by the NDT. This approach has been developed by Dr. Karel Bobath and Bertha Bobath. You can see one was the husband of the other. So they work focused on patients with neurological dysfunction, mainly cerebral palsy children and stroke. The essential problem of these patient groups were identified as release of abnormal tone, which we call spasticity, and abnormal postural reflexes, such as primitive spinal cord and brainstem reflexes, from higher centers, resulting from loss of the normal postural reflex mechanism and normal movement. I use an example of a cerebral palsy child. A cerebral palsy child, they have abnormal muscle tone. They sometimes are very spastic or they are flaccid. They have problems to integrate the reflexes. Primitive reflexes such as palmar grasp, they do not reintegrate sometimes, and this would not lead them to be able to do active handling of the object using their hand. And they have problem to develop normal movement. So these were the big problem they identified. So when they developed the NDT approach, they were aimed to address these problems using a hands-on approach, a guiding of the movement. So here they view the role of sensory feedback as a very critical in inhibiting abnormal reactions and facilitating more normal movement patterns. NDT, it uses physical handling. You have to touch the patient, but with several techniques. And they use the key point of control. There's key point of control. Where do you hold to maintain control? These key points of control, they are either the shoulders, the pelvis, where you have to hold, where you have to facilitate, let's say, rolling of a child, or sitting or standing. You have to maintain those key points of control. They are aimed to support the body segment and assist the patient in achieving active control. Sensory stimulation is used during treatment. Sensory stimulation can either be visual, auditory, or even manual stimulation. Posture alignment and stability are facilitated while excessive tone and abnormal movement are inhibited, either by prolonged stretching, using a neutral warmth, using weight bearing. Plenty of the inhibition techniques have been described here. So selected activities are that function relevant and vary in terms of difficulty and environmental context. The other approach, we already mentioned PNF in short form. This was developed by Dr. Herman Kabat and Maginot. They viewed synergetic patterns of movement were identified as a component of normal movement. By synergetic patterns we mean there's a movement which are done together. For example, I cannot hold these glasses to my eyes. I will have to bend my elbow, I will have to use my fingers and the wrist. So there's movement which are done together to complete a task. Those one we call synergy. So synergetic patterns of movement, they were identified as part of the normal movement. And later, someone called Voss joined the group and she added something else. She added an emphasis on the development, where she included a practice of variety of activities such as rolling, prone on elbows, quadruped, kneeling, half kneeling, modified plantigrade, and standing and gait. Here, modified plantigrade, it is when someone is standing, both feet touching the ground and with both upper limb holding for support. They looked at extremity patterns of movement and they noticed that they are all rotational and diagonal in nature. I'll give a very example, same using the glasses I just spoke about. If I want to take these eyeglasses from here and put them to my eyes, actually when I do this, there's always a rotation movement, whether you want it or not. I will hold them with my wrist. See, the wrist is turning inside, okay? But when I come, it will turn inwards. So you hold like this and then you come like this. There's external rotation which will end in internal rotations. So they checked a variety of movement. They noticed all the movement, they have a rotational and diagonal pattern in nature. If I want to hold a glass of water, I will hold from here and then I will bring here. So there's always that pattern. There's a rotation. So those ones, they label them as D1, D2 diagonals. So they notice that movement are diagonal and rotational rather than straight plane movement. Therefore, they thought of coordination within and between pattern that has to be very stressed. A number of different facilitation techniques, largely proprioceptive. By proprioceptive we mean they use the proprioception senses of the joint to know the position of the joint in space and in time. They were utilized to facilitate movement. For example, largely proprioceptive are utilized to facilitate movement. We have examples of how we do. There's a stretch, resistance, approximation, traction. These ones, they are incorporated in training the patterns we just mentioned. Remember, I mentioned diagonal patterns, D1, D2. We have patterns in the upper extremity and in the lower extremity. For example, for the upper extremity, we have a D1 pattern. It starts in extension of the shoulder, extension of the wrist, the elbow, the wrist, internal rotations. So this is the pattern. It starts like this and it goes in the opposite. Where you flex the shoulder, you rotate externally, and you flex, and you do this. So these are the patterns, but while they do the patterns, they incorporate either a stretch at the beginning or a resistance. They can either approximate. By approximate, we mean compression of the joint with the aim to facilitate movement. This is a D1 pattern. We have a D2 pattern. It starts from here and then it goes here. Remember I said that sensory input was viewed as very important. So they keep asking the patient to look at the movement, to follow the movement. They talk to the patient to tell them how to do and if they're doing it better. So precise manual contact are used to provide important directional cues. The therapist has to hold a specific way. How do we hold? How do you guide the movement? So it has to be precise and enhance function of the underlying muscles. So that was more of the PNF. The last one, which is the neuromuscular or the sensory stimulation techniques by the nerve. These ones, it's a number of therapeutic techniques that can be used either to facilitate, to activate, or to inhibit muscle contraction. So we have to define what do we mean by facilitation, activation, and inhibition. Facilitation refers to the enhanced capacity to initiate a movement response through increased neural activity and altered synaptic potential. Activation here, on the other hand, it refers to the actual production of a movement response and implies reaching a critical threshold of neuronal firing. Inhibition, it refers to the decreased capacity to initiate a movement response through altered synaptic potential. In simple terms, facilitation, you facilitate a movement. Inhibition, you inhibit, you avoid the movement. Activation, simple, you can cause the muscle to contract, simply as that. We have the last one we call the compensatory training. By the term you understand, compensatory. It's when recovery is not possible. We learn compensation, how to compensate. The focus of compensatory training is early resumption of functional skills using the uninvolved side. We use same example of the hemiplegic patient who might be taught how to dress using the less affected upper extremity. Or a paraplegic patient who might gain functional mobility and wheelchair independence using their upper extremities because the legs are not going to work. So that type of training is geared toward a compensatory training. Central to this approach is the concept of substitution, which we had already mentioned earlier. The patient is made aware of the movement deficiency. Either cognitive awareness is developed. Changes are then made in the patient's overall approach to functional task. Alternative ways to accomplish the task are suggested, simplified, and adopted. If we use that example of a paraplegic, someone has lost the function of the lower limbs and there's no possibility of them to recover, the only option that remains is to train them wheelchair skills. In that sense, they will need to have the awareness of what functional deficit they have, understand and accept to learn alternatives for them to be able to move around using the wheelchair where they will be pushing themselves with the arms. If you do that, you are more into a compensatory neurorehabilitation strategy, which is also suitable for some patients. A second central point for this approach is modification of the task and environmental adaptation to facilitate relearning of skills. Ease of movement and optimal performance. We also have an example. A patient with unilateral neglect, one side neglect, is assisted in dressing by color coding of the shoes. For example, red color tape on the left shoe and the yellow tape on the right shoe. One of the major criticisms, because they are, for this approach is that it focuses on an involved segment, may suppress recovery for certain patients and contribute to learned non-use of impaired segment. For example, if a hemiplegic patient fails to learn to use the involved side because they have already been trained to use the non-affected side, then you would understand that a compensatory training should come as the last result. If you use it earlier, this criticism would stand because you would make them learn not to use their side which was possibly have potential to learn. So a compensatory approach may be the only realistic approach possible when recovery is limited or the patient presents with significant impairments and functional limitation with little or no expectation of additional recovery. And I believe on this point we complete our training with these references.